Thank you for joining us at the South Texas Medical Society meeting. We're excited to bring you this Zoom conference, and please bear with us. We'll see how things go as we move through this. I'm going to talk to you a little today about the perspective of healthcare in our new world, our COVID world, as obvious by the fact that we're coming to you virtually today, as well as try and give a little spotlight on what has been affecting emergency medicine, and not just COVID, but other issues affecting emergency medicine as well. So let's start with the obvious issue is the big story of 2020, and that is, as of today, the death of over 200,000 Americans from COVID. There was no way in any dialogue that involves healthcare, emergency medicine, hospital medicine, just healthcare in general. In fact, there's no way you can discuss politics or anything else today without bringing to light the fact that COVID exists. Those of us still working in the emergency department know very well, and unfortunately firsthand, I've seen many patients expire from this. It's a real problem and has dominated the story for quite a while. In fact, if you go back a year ago and asked Americans what was the biggest issues facing them today at that time, they would have told you healthcare, which is still true today, and the economy, probably still true today. But you'll notice what's missing from here, completely missing, is the presidential election. In 2019, we still hadn't really, I don't even think at this point last year we knew who the Democratic candidate was going to be or officially declared. In fact, I don't think we even knew who it was at the end of 2019. It wasn't until early 2020 that Biden declared his candidacy. So didn't even fall on the radar. And then we had things like education, the environment, foreign policy. All those things meant something to people. This year, they're so small in comparison to the amount of time people are focused on healthcare and the changing economy, that those other issues have fallen off. Not that they're not important. Education is still important. Immigration is still important to people. But healthcare, economy, and now even the protests regarding Black Lives Matter, integration, and so forth like that, as long as with the other side of that same discussion of how do we go about this problem with dignity and respect with the police departments. So it's taken over so much of what's going on that COVID and economy has really shifted people's view of what's going on in the world. It's been an interesting and long ride, to say the least. So let's talk a little bit about healthcare in the U.S. economy. So if you follow healthcare trends, I don't think this will fool anybody, that we're looking at in 2019, we were anticipating, we actually spent about $3.8 trillion in healthcare spend by the government. And then the projection was in 2027, we'd be almost double that at $6 trillion, excuse me. Notice there was no space when the slide was made for 2020. And 2020 far exceeded what anyone had anticipated because of the bailout of the healthcare system by the government, which is obviously still not done. Not only the CARES Act, but we have other issues coming along and other funding coming through Congress, hopefully, over the next few weeks that will help prop up some of these issues in healthcare. So spending in healthcare has been tremendous. The impact of healthcare to the individual, though, cannot be ignored. It is a problem that has caused the greatest number of bankruptcies in the country are due to medical bills, and has driven many, many people to poverty. Again, if you look at through 2018, we saw a sudden increase, or if you will, decline in the number of people that could afford to pay their bills. That has precipitously dropped now when you look at what's going on in COVID because of the shift in the employment status of so many people, where they will have lost their commercial insurance and unable to go through the ability to pay bills. We'll talk about that a little more. What is the mindset of people in the COVID and post-COVID world as it respects to healthcare? Well, first off, we had no choice during COVID if you were a patient about your elective procedures. They simply were not getting done. Hospitals, surgery centers shut down. ORs closed their operating rooms, hospitals, closed their operating rooms to procedures or elective procedures and remained open only for emergencies. Surgery centers just shut down. The impact that had on one of our largest competitors envisioned was overwhelming, because a significant percentage of their business is surgery centers, and they were just shut down during that period. So people had no choice but to postpone their elective procedures. It's felt that people will continue to postpone. 60% of people have responded that they will continue to postpone elective procedures going forward. That's going to have a significant impact on the healthcare system. Obviously, the loss of employment with the rapid rise of unemployment due to shuttering of businesses during COVID will have a significant impact and burden on the healthcare system as uncompensated care continues to rise. Good news, and we'll talk about it a little more, is the impact on virtual healthcare platforms. 20% of Americans shifted to virtual platforms. Even elderly patients were able to figure out how to get some of their care virtually. And as a result, we've seen a big increase in virtual care. But from an emergency medicine perspective, those patients that were our 99281s, 282s, and even 283s, the lowest to intermediate cares, will never be returning to the emergency department. They have figured out Plan B. They have figured out how to take care of those sore throats, the sinusitis, the upper respiratory infections, even mild gastroenteritis by contacting a virtual provider. Is there a reason to sit in an emergency room waiting room for 2 hours to be told the same thing you can be told virtually? So I think it would be realistic to believe these people are not coming back to the emergency department. When that happens, relatively, the acuity of the patients in the emergency department will increase just by the attrition of the other patients. We, the providers, have to be ready to anticipate that change, because it's going to happen. In fact, most of us can see it happening already. I know I worked last week, and I would say the number of patients that were the typical, oh, what are you doing here type patients, just weren't there. They just weren't there. And we're starting, I practice in South Florida, and the number of COVID patients the last 4 weeks, thank God, has started to decline from where it was 6 weeks ago and then back in March. 6 weeks ago, it was every other patient was positive. And so people stopped coming to the emergency room just like they did back in March. We've seen some of that return, but not the return of those less acute patients. They're not coming back. The other big impact to the provider or patient mindset, rather, is cancer screening. The cancer screening is a problem that in the last several months has dropped precipitously the number of people that are getting their cancer screening done. What will be the impact of this going into the future on the number of, as of yet, undiagnosed but to be diagnosed later cancers at later stages? That will have a significant impact. We'll talk about that a little more when we talk about the impact of COVID on the insurance industry. What are the priorities then if you're in the healthcare model going forward? Well, first thing, let me just say from, again, emergency medicine perspective, will be the ability to flex our staff, whether it's the nursing staff, the provider staff, NPs, PAs, physicians. I think we've all felt it. Certainly the NPs and PAs felt it harder than others when volumes dropped, and we'll talk about volumes in a few minutes. But as they dropped, they were probably hit by decreasing the number of hours and or shifts that they were actually working. There had to be some adjustment, and unfortunately, a lot of it fell onto their shoulders. But we also have to be ready on how we're going to manage surges in the emergency department, because those likely will also be coming when we have other rounds of the pandemic. Hopefully, somebody prove me wrong and hope it doesn't happen again, but I think it's unlikely, especially as we head into flu season. We're going to see more of it. Another big issue that we have to address from a healthcare industry perspective is going to be burnout, stress. I think everybody knows about the young lady in New York who was an ER doctor, contracted COVID, got better, came back to work after just a few shifts, was overwhelmed with the volume of death. That was the issue. She left work, went down to her parents in Virginia, and unfortunately successfully suicided shortly after that. She had no prior history of suicidal ideation, so clearly this was burnout and stress at its most extreme form. But I think if you speak to your coworkers, and you should speak to coworkers, this should be an open dialogue, that you're going to find a fair amount of stressful situation and pain points that we're all experiencing. The other thing is, and again, a big issue to providers, is adequate PPE. Back in March and April, it was not uncommon to find facilities that just couldn't get their hands on enough equipment, especially PAPRs and so forth, to be able to intubate people safely. And then we're running into an issue today where we have hospitals that are still running short. And while the providers have been able to secure their own PPE, the hospitals are asking not to wear it because it makes the nursing staff feel like they're not adequately protected. That kind of approach is the absurd, but it's happening. We also have to deal with what is causing and how do we deal with the increased frequency of COVID in minority and underserved populations. Obviously, underserved don't make sense. They're not getting care early. And the other issue is the fact that they're a minority and somewhat, we'll say, less privileged in their living situations, have multiple people living close together and end up with spreading disease. And not uncommon, unfortunately, to have whole families being wiped out by the single pathogen, which is just devastating. Then lastly, as a society, is we still haven't developed any treatment, outpatient treatments for COVID. We have some, drugs that seem to show promise on the inpatient for the most severely ill, but we really don't have anything that's shown great promise on the outpatient side. And so we're kind of beholden to when will that vaccine show up. Hopefully it shows up relatively soon, but when it shows up, we do need to make sure it's safe, of course, and has not skipped any phases of a trial. If it does skip phases of a trial, let me know how that works out for you, and then I'll decide what I'm going to do. But I would be cautious, of course, but very hopeful that that comes along because we haven't been successful in finding a treatment like we are with most viruses. If you think about it, most of them we have no idea how we treat. What's going on in Medicare spending and how is it going to be impacted going forward? Well, you can see that the number of eligible seniors over the next 20 years, not surprisingly, is going to go up. The largest volume growth in population was the baby boomers, and myself, one of the baby boomers, is rapidly approaching Medicare age. Don't tell my son. In fact, I may even refuse to take Medicare next year just so I don't have to admit I'm 65. That's a possibility. But that volume of people approaching 65 is going to increase tremendously. And when it does, the spend on Medicare is going to go up dramatically. You can see every year there's been an increase in the amount of money spent on Medicare enrollees now. And while the increase isn't dramatic from year to year, you couple that with the number of people that are enrolling in Medicare, and the burden on the Medicare system is quite significant. We'll see some shifts in Medicare that may have an impact on mitigating some of this. Some of it will be a shift to different care settings. Certainly, we're going to see more home care. That will include a little bit of the telehealth market. Nursing homes are doing things, and SNFs especially, doing things we never thought they would be doing. We send people home on outpatient antibiotics. We'll send them back to SNFs. Back in the day, 20 years ago, SNFs never did anything that was that dramatic. And now, they're providing more and more care that used to be provided in the hospital. And we're going to see that extended quite a bit. Of course, urgent cares, freestanding EDs, all that's going to shift patients out of the hospital, but not so much impact the cost of care for Medicare as much. Value-based programs are going to be a big impact. We already live with MIPS, right? A reimbursement system based on quality performance. On the inpatient side, we're seeing a bundled payment system, BPCI, the A is for advanced, where the risk is going to be taken by the provider on what the spend is essentially on a given patient from the point they enter the system for up to 30 days. That includes SNF care, rehab care, home care in that 30-day module, 30-day period, and bundle that care and put that burden on the provider to control care during that entire 30 days, even though the patient may only be in the hospital for 3 or 4 of those 30 days. So that's a value-based program that could very potentially have positive impact on the Medicare spend going forward. What about Medicaid? Now, Medicaid is one of the biggest budget items in any given state. Average state, it's about 30% of a state's spend. That's no small amount. And so it has to fit into the what are we going to do, what are we going to fix. In the short period of March to the beginning of May, 12.7 million people were enrolled in Medicaid in just a small period. That's a huge increase and a burden at the state level. How is that going to relate to those states that expanded Medicaid during the, if you will, Obamacare? How are they going to be able to sustain that? And what's going to happen becomes more relevant now with the passing of Ruth Bader Ginsburg on the Supreme Court. There is a case where the Affordable Care Act is coming to the Supreme Court, and it may have a significant impact on what happens with that care, which will impact spending by the states in their Medicaid budgets. So it'll be interesting to see how that shapes out. Well, what about our commercial insurers, our friends that were so concerned about their survivability, who have averaged to grow their revenue by almost 150% over a 4-year period, and their margins double in 2019 over 2018. Well, how'd they do during COVID? Believe it or not, they did great. Well, they did great because if everybody's staying home and we've canceled all the elective surgeries, right, they had very little money spent but continued to collect premiums. What are they going to do with that money becomes interesting. Are they going to move more providers to capitation models? Are they going to move to other strategic plans they had but were restrained by capital and now have excess capital? Now, some of that spend is going to catch up, obviously. People are going to go on and have some of those elective surgeries, but not all of them. And then you have to wonder, right, well, how important were those surgeries if people end up not having them? And then the real question to the insurance industry, while they may be, we'll call it rolling in it right now and very happy about it, with those delays in physical exams, annual exams, and cancer screenings, what's the medium range impact in 3 to 5 years for cancers that get diagnosed now a stage or 2 stages later than they could have been discovered with screenings? The cost of that care goes up quite significantly. And when that happens, the story for the insurance companies may actually change. We'll have to see. Whole new range or participant, if you will, in healthcare. Walmart, and this doesn't just apply to Walmart, but Walmart has opened clinics, right? They have their clinics inside of Walmart. They're expanding them rapidly. We'll call them retail healthcare, if you will. CVS, Walgreens have all done the same. And then Walmart has gone out and partnered with a pharmacy benefits company and also at the same time started selling insurance services. That sounds crazy, but CVS has already done the same thing. They partnered, actually they bought a pharmacy benefits manager, and then what they do? They bought Aetna, a pharmacy chain, bought its own insurance company last year. They bought Aetna. So they're doing the same, this incredible, will not care so much as cost integration model that will greatly impact not access to care so much, but certainly the cost of care going forward. We're seeing so many parts of the healthcare spectrum now being combined under one entity. And lastly, of course, is will Walmart then become an insurance company if CVS has already done so by buying Aetna? What are the other large retail stores going to do? We don't know yet. What about from the provider's perspective? Well, interestingly, the doom and gloom of the provider has been foreshadowed or forecasted rather in numerous papers talking about physicians leaving healthcare at an incredible rate, physicians going bankrupt because of the period where they were not seeing patients, and then they were seeing patients at only a third of capacity. I had a doctor's appointment I went to. I had to sit in the car and wait until I got called to come into the waiting room because they only had one waiting room person at a time allowed in and 2 patients in the back for the doctor. That's about a fraction of what you would typically see in a doctor's office. That had a huge negative impact, and so people were foreshadowing the death, if you will, of these practices. There are certain things that have been propping up these practices. Obviously, the CARES Act has provided funds back to these practices so they didn't have to, or they can unfurlough, if you will, their employees and bring them back when the volume started and keep them whole. But getting the money wasn't easy. It took a lot of jumping through hoops for individual practices to make sure they filed early. In some instances, it just didn't work out as they wanted. Believe it or not, health plans became altruistic and paid people in advance based on prior allocations of funds in previous years. So again, they could prop up businesses slightly. you had a loosening of restrictions on telehealth. So doctors were able to enter the telehealth market by decreasing barriers to health. The biggest barrier to telehealth wasn't necessarily sophisticated platforms. You could use, and doctors did use, their telephones, and they did use their iPads, however, technically not encrypted and not ideal for a telehealth model. But the other platforms became easier to access, credential doctors a little faster, but more importantly, there was now a mechanism to get reimbursed. Up until this point, the government was not reimbursing for telehealth. So while it would make sense to anybody else to have your beneficiaries enroll in a telehealth program and receive care at a discounted rate, our government, while they may have recognized it, was not willing to pay for it just yet. And so it was moving slowly. Well, the government made that change and started paying for it. And I think that was really an impetus for the rapid growth in telehealth we saw during the early stages of the pandemic. What else can providers do going forward? Well, you'll see the merger of groups. There's going to be smaller practices that are going to have to merge with larger practices. You're going to see, certainly in our space, in the hospital-based managed practices, emergency medicine, hospitalist medicine, anesthesia, and so forth, you're going to see mergers and acquisitions. There's plenty of groups out there of moderate size and large size that are struggling because of what happened with COVID. I mentioned one, Envision owned numerous surgery centers, and as a result of that, took a significant impact. And not talking out of school, it was in the newspaper that Envision was contemplating bankruptcy. I don't know that we'll see that happen, but it's been in the newspaper. I mean, they're struggling. Will people sell their companies, whether it's an ER company or even private practices, to private equity firms or PE firms? We're seeing that go on now, not just in the large groups, like we know that KKR is involved, and we know that Blackstone owns Team Health, and Onyx owns SCP Health, or has ownership interest, let me say. But even in private practices, we're seeing groups own dermatology practices. They own orthopedic practices. We're going to see primary care practices merged to form multi-specialty groups, which have been around for a long time, but are going to become more popular, more prevalent, and more necessary. And so you're going to see more of this occurring, all right? You're also going to see maybe partnering with health plans to have some access to funds that weren't accessible in the past. There's also going to be a shift to a stay-at-home economy, if you will. Obviously, we're all, if I was in a business, the last business I want to be in is commercial real estate in the year 2021. People, companies, everybody has figured out, some struggling, kicking and struggling, how to work from home. Those of us obviously in the emergency department don't work from home, but if we have any other business interests we're involved in, we're doing them at home. We're traveling much, much less. I used to travel an average of probably 20, 22 days a month, and I travel maybe 3 or 4 days a month now. So this at-home economy is going to have significant impact on the healthcare industry. Obviously, I mentioned telehealth for one, and as the technology gets better for virtual care, the better people are going to do. Barriers to success, well, big barrier to success from at-home healthcare, for one, is do people have stable home care environments? Do they have a caregiver at home that can help do certain things? We have people with multiple comorbidities that are not going to be able to be managed at home, no matter how much they want to or we want to be able to manage their home. They're going to need hospital care. They're going to need more sophisticated care. They're going to need to have people that have higher levels of skill than you can possibly get at home or in a home health setting. So there'll be a shift, but obviously it'll never be 100%. How significant is the impact on telehealth in all of this? Well, it's significant. I mentioned before that all of a sudden we can now get reimbursed for telehealth, and you've seen a big growth in what's happened in telehealth over the last several months. You may be familiar with a company called Teladoc, one of the largest of the virtual platforms out there. Well, if you were smart enough, I wasn't, to buy their stock in January, it was $85 a share, probably a ridiculous multiple of its actual earnings. If you were to buy the stock about 2 or 3 weeks ago, it had gone to $216 a share. A missed opportunity for sure. That is how much their revenue grew. I mean, you could see at the top there, I mentioned that In just the last week of April alone, 1.7 million Medicare beneficiaries signed up, fee-for-service beneficiaries signed up for telecare. So it wasn't those that were managed by a secondary provider. This is primary fee-for-service Medicare enrolled in a teledoc-like service to receive their care. So the utilization has gone up. Now, over the last few months, few weeks, utilization has slowed down just a little bit. Certainly can't expect it to continue to expand at that rate. In fact, several of the companies, while they were expanding rapidly and bringing on providers rapidly, probably outstripped the rate at which they could bring providers on. And so their credentialing process slowed down significantly, which had some impact on their ability to provide the service they've done. The one good thing that's come out of this, maybe that's not a good thing, but the one thing we could see as a bright side is everybody has seen images of people on the street clapping and applauding. I know in Italy, it was one of the most amazing things. At 7 o'clock every night, people got on their balconies just to basically make noise and cheer for healthcare workers and primary responders. It was pretty moving. I know when I'm in the ER every night, a different restaurant was sending food to the emergency department to make sure the staff during the day and at night had food. People didn't have to bring meals. We had restaurants sending food in every shift, and somehow they coordinated so that we weren't getting 12 meals one night and none the next. It was coordinated amongst a group of restaurants, and it was pretty moving. And so the net influence is, they say that 68% of the population has a more positive reflection on healthcare workers, 65% on hospitals. Nobody ever had a positive feeling for hospitals in the past, right? And healthcare workers, doctors, providers, and others never really were, in the last 20 years, held to the esteem they were in the 60s and 70s. But all of a sudden, we've regained that position because of what we've done, what you've done during the pandemic. We got dressed every day and went to work. In my 35 years of practicing medicine, never before had I gone to work and wondered if a patient was going to kill me. We'd gone to work and, patients died. We all got used to that. We all understand. We had our share of gunshot wounds and, acute MIs and whatever were going to die. We never expected to see the volume of death we were seeing in the ER, multiple deaths on a given shift, but never did we have to wonder if we were going to catch something that we were going to die from at such a large volume. Yeah, we're at risk. Patient comes in with some other disease, but nothing like this. And it was unseen. You had to assume everybody had the disease. It wasn't like they all came in sick. In fact, that was part of the issue. We had patients coming with totally unrelated complaints that ultimately ended up testing positive. So that's my big face on where we are, what's happening in healthcare in general. Let's shift a little bit to emergency medicine for the last 10 or 15 minutes. I will talk about what's happened and what is happening and where it's going in emergency medicine. So first, let me point out this little slide. As you can see, the volume over the last several years of increase in utilization of freestanding EDs, urgent cares, retail clinics, not so much, telemedicine slowly. If you extended this graph out to 2020, that bottom line would probably exceed where the urgent care line is today. Telemedicine has shot up tremendously, and all at the expense of one place, and that would be the emergency department. If you look again up until 2015, 2016, we all grew up in a world where every year we read articles about the expanding volumes of emergency medicine patients in the country. What are we going to do with how busy emergency departments are going to get? Well, unfortunately, looking back, that problem solved itself. Somewhere around 2017, 2018, volumes started to flatten out, and you'll see why in just a moment. Well, let's look at it. Volumes flattened out as freestanding EDs and urgent care started to rise dramatically, and they've continued to rise at a very pressuring rate, having an impact on emergency medicine. The impact that's had on volumes in the ER have been significant, and that at some point impacts or has impacted the economics of what goes on in emergency medicine. We'll get to that in a minute. But nothing could have predicted this. Nothing could have predicted that by April of this year, we would have seen an almost 50% decline in ER visits. And look, it literally fell off a cliff. Where you see it falling down is almost to the day, or at least the week, where this was declared a national emergency. As soon as that happened, that we recognized what was happening in New York, where the number of beds in hospitals were being outstripped by the number of patients, people stopped going to the emergency department out of fear, not because they were altruistic and wanted to give up their bed. They stopped going to emergency departments out of fear that they would catch this unseen disease. In fact, we know that COVID cured coronary artery disease. It cured congestive heart failure. It cured cancer. It cured bowel obstructions. It cured so many things that normally we would have seen, that people simply were willing to take their chances at home, and a significant percentage of those died. Almost wonder if they should be labeled at some point as COVID-related deaths, because that's what they were. I mean, people just didn't come to the hospital because they were that afraid to do so. So we see this decline in volume, and we've seen it start to come back, although, again, if you extend this graph out to the end of August, the beginning of September, when we saw this second wave, if you will, the volumes in the ER dropped slightly. They've leveled out again, but there was a second slight decline when there was the resurgence, probably following Labor Day weekend, and we saw a slight decline in volumes. So significant. Hospital medicine, not as dramatic, about a 25% decline, and they recovered faster. Partly the decline was not as dramatic because the length of stays for the COVID patients was so long. If you have long length of stays, your service stays busy, even though you're not seeing new patients. The volume of new patients has gone down, but the length of stays and the bed occupancy rather, did not change. So not as dramatic in hospital medicine. Let's talk a little bit about emergency medicine from a payer perspective. If you look at this, you can see that patient margins are basically all sit in the commercial bucket. That's where the margin is. If you're looking at, and Blue Cross and Blue Shield gets its own line, but if you put all that together, Blue Cross and Blue Shield and commercial, that's where the revenue margin is. Medicare probably comes close to paying most of its bill when it sees a patient, but Medicaid, self-pay, nowhere near it. Those all operate at losses. So why does commercial pay so much more than the other payers, if you will? Well, the answer was simple. It was a 1986 uncompensated care magnate that came out, and that was EMTALA. So the government decided we would now see everybody in the ER, whether they paid or not, which is no political discussion there, probably the right decision. The problem is the government wasn't going to pay for that. And so that cost got shifted to commercial insurance, which the government was very happy to support. And so that's how the commercial became so unbalanced, if you will, compared to the rest of the margins by other payer classes. Why is that so significant? Well, if you look at the volume in emergency medicine, Blue Cross Blue Shield and commercial makes up only 20% of our patients, right? And then we have Medicare, Medicaid, and self-pay sitting at the top there, but Blue Cross and Blue Shield are at the bottom. They make up 20%. If we look at our revenue, okay, Blue Cross and Blue Shield make up 55% of the revenue, but only 20% of the patients. Okay, we following that? So we are truly dependent on our revenue by only 20% of the patients. Medicare and Medicaid make up 45% roughly, and then you have a few percentage points coming in for self-pay. Well, when we talk about what's happening on the legislative level in just a minute, it's that commercial, I'm at a handicap here remotely, I can't point, but it's that commercial that you're looking at, that 40 and 15% on the slide that's being compressed by the legislative efforts to decrease commercial reimbursement by moving people in network, that we're going to feel, which will have a greater impact because that's where our revenue sits. The other thing you have to consider is what happens to payer class in the post-COVID era. That 15% self-pay has already jumped based on the unemployment increase. So those that were commercially insured either got covered under COBRA or less likely, because they were not, few of them were professionals that could afford to pay their own COBRA. And as a result, they moved into the self-pay bucket, which only pays 5% of our revenue. It's a very small piece. So the volume of that's going to go up, drive down the other size of those buckets proportionally, and as a result, revenue will suffer quite significantly unless there's some preservation of that commercial and Blue Cross Blue Shield bucket, which there won't be. We're going to be more and more at risk there. And let me just mention that on the Medicare side, they've already published that in 2021, reimbursement for emergency medicine is slated to go down by 6 or 7%. So we have, always nice to have new pressure we hadn't, well, I won't say we hadn't expected, we expected it. Here's again, one of the challenges in the industry. Again, you can see those graphs at the bottom represent the decline in commercial payment in emergency medicine, yet provider costs continue to climb over the last 5, 6 years, at least 4 or 5 years rather. We're about to see a dramatic change in that. I think everybody knows that. The volume changes that have occurred and then the reimbursement change I just described tell us something has to change. It can't stay as it's been in the past. So we should anticipate those changes coming in the not too distant future, and the not too distant future was probably yesterday. So if you can, if you will, let me describe briefly the surprise billing issue. That's the legislative issue I was talking about. By now, most people have heard about it. It's been in the newspaper. Congress has talked about it. The White House has talked about it. What surprise billing is out-of-network billing. It occurs when you go to a doctor, right? Well, let's talk about it in perspective of the hospital. You go to a hospital that's in your insurance booklet and says, okay, I can go to hospital A because they're in my plan and I can go there and get my laceration sewn up. And there may have been 2 other hospitals in town I could have chosen, but I chose A because it's in my plan. And it turns out that the ER group is not in your plan. Or you go to the OR with your appendicitis and the surgeon on call is not in your plan. Or the anesthesiologist or the radiologist or any of the hospital-based providers, which you had no option of choosing once you showed up in your in-network hospital. And so that's the surprise bill. They now get balanced bill from these providers, which they have a right to do. And so when they get that balanced bill, the patients are surprised. What balanced billing is not, this does not relate to deductibles and co-payments. The surprise on the deductibles is that because the cost of healthcare continued to rise so dramatically, employers had to shift the cost of healthcare onto the employees. So deductibles have gone up into the $3,000 to $5,000, even $7,000 range. If you are a $35,000, even $50,000 a year employee, and you have a $5,000 or $7,000 deductible, you have an option when you seek healthcare that exceeds your deductible or approaches your deductible. Your option is either you feed your family or you pay your deductible. And so you have become the commercially, what I call commercially uninsured. That's the greatest percentage of people today that are probably getting pushed into bankruptcy or bankruptcy situations because they simply can't afford to pay their deductible. They have a job, they have commercial insurance, they can't afford to pay it. They may need to use it for catastrophic care, okay? You get put in a hospital or you have a baby. A friend whose daughter's having a baby, and she just told me the bill's $38,000. I would negotiate with the baby after the baby's born if you think it was worth it. I mean, that's crazy. But if you're employed in a company as a $5,000 deductible now, they're going to have to pay that when they have that baby. And that's just huge. And that's going to force people not to pay those bills and enter into that bankruptcy group. So deductibles are not the same as surprise bills. I want to make sure we're clear. The surprise bill is an out-of-network bill. A lot is going on in Congress. There's good, bad, mostly bad on the House side and Senate side. This is the bill we actually supported, the Ruiz bill, which was doing baseball-style arbitration, where both sides would submit a bid, the insurance company, the provider group, submit a bid, and then the mediator or arbitrator would sit there and decide which bid he was going to accept. And there was no negotiating. It was just one bid or the other. So hopefully we'd get people back to making rational decisions and, not sending a bill for $1,200. The insurance company said we'll pay $100, and then thinking we're going to meet in the middle. That's not going to happen. The arbiter is going to pick one or the other, not both, not a middle point. So that's actually been in place for a while in some states and been effective. It's an all or none approach, and it's designed, again, to make people be rational. There's been opposition to it. People are afraid it'll increase premiums or pay costs to the patient. This has been in place now for several years in New York, and that has not occurred. So we support the Ruiz bill. I will tell you, however, while it's still very significant and an important issue to those of us in emergency medicine and practicing and elsewhere, it's on the back burner. COVID, the economy, and the presidential election have moved all of these issues to the back burner. In fact, while it was still relevant in the first half of the year or first quarter of the year, once COVID hit full swing and had its devastating effects on the economy, Congress had their work cut out for them. And while there were other things that needed to get done, this no longer was sitting on the front burner as it had been for the year before, and it was very relevant the year before and scary. This year, it's kind of hit a little hiatus, and we'll accept it. We'll take it for now while we're trying to figure out what's going on. So what are the pressure points in emergency medicine that we've discussed today? Well, volume, we've talked about. And that, again, I don't think will return to the same levels. Payer class and reimbursement pressures from the payers, which is going to be significant. The impact of COVID on the payer buckets, if you will, the increase in self-pay, unemployment, and then compensation trends. Compensation had been moving up. It's going to be steady. What's the counterpoint? What can we do? Well, we'll expand our sphere of influence and care, like into telehealth and other unaffected parts of medicine. Some, it's not uncommon for emergency medicine docs to go into pain management or other groups where you're going to see people. Again, they're probably still impacted by people not wanting to seek care because of COVID. We'll enter new markets. One thing we can all do, and I will encourage people, is advocacy. Last year when I was here, I did the same thing. And that is, you can write letters to senators, you can write letters to congresspeople. I went to Washington, I think 3 times last year. I mean, I think since my high school field trip to DC when I was a kid, I don't think I had been to Washington maybe once or twice in the 40 years since then. But I went 3 times last year to meet with senators and congresspeople because it's that significant. This will be a devastating blow to the industry. I think we're going to see groups merge. As I mentioned before, while Congress and others are bemoaning the utilization or the impact of private equity dollars into healthcare, it's going to be unavoidable in the industry going forward because the impact COVID has had on some of the practices. To be able to grow and sustain your practice, you're going to need some capital infusion from elsewhere, and that's what's going to happen. Then lastly, we're going to have to redesign, or if you will, align compensation models for providers, whether it's NPs and PAs or physician providers, are all going to be impacted by this dramatically by economic reality. If volumes are dropping, if payer classes are switching, if reimbursement by payer classes are going down, well, it's no longer realistic to believe that your compensation models can stay the same. If you're in private practice as a cardiologist, family practice, GI, you name it, if your volume went down by 45%, you can assume that month you will not be making the same money that you made the prior year in the same month. If the volumes continue to feel pressure, you'll do the same. If you see your reimbursement by your largest insuring group go down, you're going to feel the same pressure, and you're going to see either take adjustments to your pay or adjustments to your coverage model. You may eliminate some of the people in your office. Well, I think ER groups are going to have to face some of those same difficult decisions. What are we going to do with staffing patterns if volumes don't return? What are you going to do with provider compensation models? How do you align provider compensation models so there's no broad cuts, if you will, but there's just a reality? Volume goes back up, then compensation models will rise with that. Volumes go down, then compensation has to go down with it. So we're going to see some dramatic changes in emergency medicine, and I don't think they're going to occur next year or the year after. I think they're occurring this year. I think they're going to be dramatic. Some of them will feel more dramatic than others, but I can assure you they're going to reflect what is reality, because I think I included have lived in that environment where we were in a bubble and protected from these economic factors when we worked on clinical shifts. I think those days are over. At that point, we're done. And I would like to stick around, if you will, not virtually, but in real time, to answer any questions that you may have. The group, the South Texas Medical Society, I thank them for being brave and courageous enough to try and do this during these difficult times. And they've arranged so we'll be able to do a Q&A. So please submit your questions through the chat feature, and we'll be happy to answer them.